Hello everyone, welcome to today's video. Today the topic of the video is the 2 syndrome concept, origin and current status. The 2 syndrome concept originally was given by Timothy Crow. Well, it has been covered in CTP, but a very short paragraph has been given on this topic and it is on page number 1418. So I decided to make a long video going through the whole article, the original article which was being published by Timothy Crow himself. So we'll be looking through the whole topic, how he was able to conclude and come to the 2 syndrome concept of schizophrenia, what were the previous studies which was being conducted that led him to came to a conclusion of the 2 syndrome. So the reference for the today's video is the 2 syndrome concept original article which was being published by Timothy Crow in 1985. So here he is, Dr. Timothy John Crow, looking through one of the specimens of the post-mortem studies. This is the hospital, the Norfolk Park Hospital, that is situated in Harrow, London, where all the studies were being done. Dr. Crow used to work here, and the previous studies which was being conducted, which led to the foundation of the 2 syndrome concept by Dr. Crow, was also being conducted here only. So we'll be firstly looking into the prior studies that formed the basis of Dr. Crow's work. So these 3 studies were, the first of the study was the CT based study in schizophrenia patient by Johnston et al, which was being conducted in 1974, and a subsequent study was being conducted in 1978. So in chronic institutionalized patient, there was seen that in the CT scan it was associated with increase in ventricular size as compared to the premorbid matched controls. Also, it was correlated in schizophrenia patient to be associated with negative symptoms. That is, the change in the ventricular size was associated more with the patients in schizophrenia that were having the negative symptoms. However, this change in the ventricular size could not be explained by previous physical treatment. This was first study which was being conducted, and this has an impact in formation of the 2 syndrome concept. The second study is the therapeutic study of 2 isomers by Johnston et al. The isomer of the antipsychotic that was chosen was flupentixol. Flupentixol, they have taken 2 isomer, the alpha isomer and the beta isomer. The beta isomer was 1000 times more potent as compared to the alpha isomer. So they have introduced these antipsychotic in the institutionalized patients. They found that alpha isomer works more in the acute patient as compared to the beta isomer, which worked more on the chronic patients, and they tested the dopamine blockade hypothesis of the antipsychotic effect. Patient with negative symptoms, however, showed little tendency to improve on placebo, and no differential response was seen to D2 blockers. This third study was the post-mortem study conducted by Owen et al, again in the same hospital. So the post-mortem specimen of the brain from the patients who suffered from schizophrenia was being taken and was being analyzed. The analysis was done to mark the dopamine turnover that was being assessed by homovaleric acid or dihydroxyphenylacetic acid concentration, and was not increased. Rather, the number of D2, that is the dopamine receptor, was being increased. The number of D2 receptor in postmortem brain was found significantly related to positive but not negative symptoms that was being perceived by these schizophrenia patients in their life. So these were the 3 studies, the first being the CT scan study, the second being the flupentixol study, and the third being the postmortem study. These observations, however, presented a crisis of interpretation. That is, if schizophrenia was a unitary disease process, was this to be seen as a primary neurochemical disturbance, which was being suggested by the dopamine hypothesis and subsequently being proven in the second study where flupentixol was being used, or it was a destructive process leading to structural brain changes and intellectual impairment as a result of the CT scan studies and some earlier pneumoencephalography studies which was being conducted earlier. So a dilemma occurred that a single type of entity was being caused either by the neurochemical disturbance or by the structural change disturbance. So how come it is possible that schizophrenia, being a single entity, is being explained by both these things? So Crow suggested that there was a neurochemical component, perhaps related to dopaminergic transmission and responsive to neuroleptic medication, And subsequently there is also a structural component that is related to poor long term outcome and to intellectual impairment. The results of the flupentixol isomer trial that was being conducted by Johnston et al. Suggested the drug responsive component and could be related to the positive symptoms, whereas the result of the CT scan study that showed the size in the increase in the ventricular size and the data showing a relationship between negative symptoms and the intellectual impairment which was there more in these patients, that is more the structural change, there will be association between negative symptoms and intellectual impairment. So Crow tried to solve the crisis, the paradox that the symptoms of the disease sometimes remit and more often respond to neuroleptic drugs, but at the same time the disease is not frequently has a poor long term outcome that is unresponsive to drugs. So because of the interpretation of these results, the three studies, the paradox could not be solved. So, on the basis that there can be a potentially reversible, perhaps dopamine related, and irreversible component associated with the single entity, that is schizophrenia, Crow tried to solve the crisis and came out with the two syndrome concept, that is the type 1 and the type 2. The type 1 being characterized by hallucination, delusion, and thought disorder, type 2 being characterized by affective flattening, poverty of speech, loss of drive. Type 1 is seen in acute schizophrenia patient, and type 2 is most commonly seen with the chronic schizophrenia patient. And the response to antipsychotics, that is the neuroleptics, is good in type 1 as compared to poor in type 2. And the overall outcome is reversible in type 1 but irreversible in type 2. Also, the postulated pathological process that is involved in type 1 is increased dopamine receptors, whereas the postulated pathological process in type 2 is the cell loss and structural changes in the brain. Now, after he came with all these conclusions, we have to look into the current scenario. But there are 6 questions that are being given in the article, that are positive and negative symptoms component independent variables? Do negative symptoms identify the non-dopaminergic component? Are negative symptoms associated with poor long-term outcome? Are they more persistent than positive symptoms? Are negative symptoms associated with structural brain changes? Are these neurochemical correlates of the two syndromes? Are there EEG correlates of type 2 syndrome? So these 6 questions would further help us decide whether the two syndrome concept hold in today's scenario or not. Prior to answering all these 6 questions, we come to a very important figure that was been given in the article, that is the relationship of positive and negative symptoms with poor behavioral performance, cognitive impairment, and neurological signs. We can very well see that there is significant interrelationships among negative symptoms, neurological signs, the poor behavioral performance, and cognitive impairment, but these symptoms were unrelated to physical treatment or to the presence of positive symptoms. Coming to all those 6 questions which I have discussed previously, let's find the answer to all of them. Coming to the first questions, that is, are positive and negative symptom components independent variable? Assuming that it is true that there are indeed independent dimension, it is worth considering some limitations on the situation. It can clearly only be demonstrated in a population restricted to patient with schizophrenia. Secondly, the negative symptoms make positive symptoms difficult to elicit at times, as a result of which a spurious relationship between the positive and negative symptoms can occur. So it is not correct to say that positive and negative symptoms components are independent variables, and has been given in the subsequent findings by Nancy Anderson that it is a single spectrum, and the basis of whether a patient would lie on a positive symptom side or the negative symptom side, it depends on a multifactorial thing. It is not that it is totally independent. Coming to the second question, do negative symptom identify the non-dopaminergic component? So as the positive symptoms were exacerbated by amphetamine and improved by neuroleptics, while the negative symptoms showed little response to drug, 3 of the scientists, that is Angstens, Rotorson, and Grayson, find that symptom exacerbation by amphetamine predict potential response to neuroleptic drugs in conformity with the dopamine hypothesis. Coming to the third question, that is, are negative symptoms associated with poor long-term outcome? or are they more persistent than positive symptoms? And overall analysis indicates that in general, negative symptoms are of later onset and more persistent than positive symptoms, and impairments of self care were more likely to resolve than some negative symptoms, and cognitive and memory deficits will be there. Are negative symptoms associated with structural brain changes? So, ventricular size to be significantly related to intellectual impairment, and also others to poor premorbid personality or treatment resistance. And it is more associated with behavioral deterioration, and these structural brain changes are associated with absence of positive symptoms and the presence of abnormal involuntary movement. So structural brain changes correlates with the presence of the negative symptoms. Coming to the fifth question, are there neurochemical correlates of the two syndromes? So D2 receptors are significantly related to positive but not to negative symptoms. The enzymes, that is dopamine hydroxylase and choline acyltransferase, are not reduced in patients with negative symptoms. That is, the type 2 syndrome differs from Alzheimer's disease, in which both these enzymes are reduced. So neurochemical correlates of the two syndrome, if we compare, so D2 receptor is significantly related to positive but not to negative symptoms. So with the help of D2 receptor, we can clearly differentiate between these two. Also, coming to the sixth question, are there EEG correlates of type 2 syndrome? So the therapy resistant schizophrenia patients were characterized by a lesser degree of very fast beta activity, more alpha waves and slow waves, higher amplitude in computer EEG, and a lesser degree of acute psychotic symptomatology, but more negative symptoms such as motor retardation and blunted effect. So yes, there are clear-cut EEG findings that are there in the type 2 syndrome, that is the syndrome that is comprising of more negative symptoms. So here were the 6 questions that was being given in the original article, and they also help us to decide whether the concept of the 2 syndrome hold in the current scenario or not. So more study was being conducted by Crow, and later on he come with the modified 2 syndrome concept. However, this has been modified only to add on a few points, that is the eponym and also the abnormal involuntary movement and the intellectual impairment. So intellectual impairment and abnormal involuntary movements are absent in type 1, and these can be sometime present in type 2 also. Now a more detailed way of pathological processes that was being associated with type 2 can be elicited, that is the cell loss including the peptide containing interneuronal and temporal lobe structure, that is the hippocampus, amygdala and parahippocampal gyrus, was found to be associated in patient with type 2 schizophrenia. Coming to the conclusion, the concept of 2 syndrome schizophrenia arose from the necessity to postulate more than one dimension of pathology underlying the disease, that is a reversible one, and a potentially neuroleptic response was seen associated with that. This was at the reversible component, and the other part was a sometime progressive and relatively irreversible component associated with the deficit state and poor long-term outcome. Negative symptoms appear to be more closely related to the later component, that is associated with deficit syndrome and poor long-term outcome, as also the cognitive impairment and the abnormal involuntary movement, which was more associated with negative symptoms, that is there in the type 2 schizophrenia. The two syndromes are regarded as relatively independent processes which may coexist in the same patient but follow different time courses. They are assumed to be of different manifestation of the activity of a single pathogen. So this was the conclusion of the whole article and the whole type 2 on the type 1, that is the 2 syndrome concept that was been given by Teacher Crow. I would request you all to follow the handle Psych Kaplan and Sadok CTP. It's there in the Instagram, and it is the only page for updates on Kaplan and Sadok CTP 10th edition for psychiatry resident. It's me, Dr. Manish Roshan, signing off. I hope you have all enjoyed the video and have learned something. If you have any query, do let me know in the comment section. Thank you.